So I'm going to say right off the bat, I'm not going to do better than Mike Berger. It's past 5 p.m., so maybe we should just call it quits and go grab a beer. But if not, I will do my best to stick within the 20 minutes. So, the premise of the talk, actually, I think it's the first time we're actually talking about targeted therapies in esophageal gastric cancers, and I had a subtitle, Old and New, Good News and Bad News. So some of this is summary, and I hope I can give some new information and maybe some new perspective on some of the older studies. These are my disclosures. So starting right off the bat, we'll start historically with the first targeted therapy, which really was anti-HER2 therapy. And just as a reminder, HER2 is a member of the ERBB family, and there are 4 molecules. There are multiple ligands that can bind to them, but binding causes them to come together then to form either hetero or homodimers. HER2 is the preferred binding partner for the other 3, and then this leads to downstream signaling of multiple pathways. So as we all know, it's actually 8 years now in 2010 that the results of the TOGA study were first presented, and this is a positive study with trastuzumab. So I think what's important to focus on here is how HER2 positivity was defined at the time. So for the purposes of the study, it was IHC immunohistochemistry 3+ or FISH positive. So in other words, there were some proportion of tumors that were FISH positive that had IHC 0 to 2+. So based on these criteria, about 1/4 of tumors that were screened were HER2 positive. The majority of tumors were gastric. And of note, 75% of tumors are intestinal. Only 10% of tumors were clearly diffuse based on this analysis. To put it another way, we now have data that with diffuse gastric cancer, HER2 positivity is typically less than 5% of the time. So of course, we all know this is a positive study. Trastuzumab was added to a backbone of fluoropyrimidine and cisplatin. I think that's noteworthy because I think most of us now would use FOLFOX. The convenient thing was trastuzumab came in every 3-week and every 2-week dosing, so it was easy to pivot once the drug was FDA approved. So all outcomes were improved with the addition of trastuzumab, and notably the overall survival was 13.8 months. And this was the first phase 3 study that crossed the psychological 1-year barrier in terms of median overall survival. So what I want to focus on is the fact that benefits seem to vary based on the HER2 subgroup. So you'll see in this forest plot that the majority of benefits, the left side favors the addition of trastuzumab to chemotherapy, right side favors chemotherapy alone, that you'll see that in what I've highlighted, the patients who seem to derive the most benefit had tumors that were FISH positive, but that were also IHC 2 or 3+. So on the basis of these results, in the US in 2010, trastuzumab was approved really based on the eligibility criteria. Again, IHC 3+ or FISH positive tumors. On the other hand, in Europe, the drug really was approved based on this forest plot, only for the IHC 2+ FISH positive tumors or the IHC 3+ tumors. And this currently has implications in terms of how we screen for HER2. So the current guidelines, and these are from multiple societies in the US, really call for us to start with HER2 testing. If you have a tumor that's HER2 3+ positive, you're done, that's positive. Similarly, if it's 0 or 1+, that's negative and you're also done. And FISH really should be requested only when it's 2+ or equivocal. So moving on from this, chronologically, the next drug that was evaluated following trastuzumab was lapatinib. And lapatinib actually was studied simultaneously in 2 studies that accrued at the same time. The first study that reported on the lapatinib was the TITAN study. And again, just as a reminder, lapatinib is a TKI that has activity both against EGFR as well as HER2. So in this TITAN study, patients received paclitaxel with or without lapatinib. And based on the time when patients were accrued to the study, very, very few patients received trastuzumab. Now, what's notable also is the criteria. So HER2 positivity was defined only by FISH. So in other words, IHC was not required. The only testing was FISH positivity. So we all know this was a negative study, but if you look at the data, it did look like that potentially was a trend towards an improvement in overall survival, which did not approach statistical significance. However, response rates were improved to almost 30% for the combination. And in a subgroup analysis, they found that patients who had IHC 3+ tumors along with the FISH positivity, and this is about 50% of the group, actually did have an overall survival benefit. Their hazard ratio was 0.6, and the p-value was statistically significant. So potentially there was some excitement going into the announcement of the results of LOGIC. And this was the first-line study in which lapatinib was added to capecitabine and cisplatin. And again, patients were selected in the same way. Only FISH positivity was required, IHC was not. But unfortunately, this was also a negative study, but it did also show somewhat similar trends. Again, the overall survival was numerically better, but now the p-value was far from statistical significance. But both progression-free survival and response rates were slightly improved. In a pre-planned subset analysis, they did find that Asian patients, as well as younger patients, derived benefit, but they couldn't find any biomarker correlate for this. And of note, unlike the first study, they did not find any benefit when they looked at the IHC high-expressing tumors. So certainly on the basis of both of these studies, further development of lapatinib was halted. Next came TDM1, and this was a second-line study. As we all know, TDM1 is an antibody-drug conjugate of trastuzumab with a microtubule inhibitor. And this is evaluated in the Gatsby study, and it was compared to dealer's choice of a taxane, either paclitaxel or docetaxel. And by the time this study had come around, trastuzumab in the first-line setting was standard of care, so 3/4 of patients had received an anti-HER2 therapy in the first-line setting. It's notable also that in terms of the HER2 positivity criteria, we are now using kind of the contemporary and accepted criteria. But what's notable was that a biopsy was not required prior to study entry. I think Elena spoke this morning about the fact that in our data, and now in actually multiple prospective studies, up to 30% of tumors that were HER2 positive at the time of first-line treatment actually become HER2 negative after progressing on trastuzumab-based chemotherapy. So given the fact that a new biopsy was not required, it's certainly possible that some proportion of tumors were HER2 negative. But irrespective of the reason, this is an ultimately and completely negative study. So finally, in terms of HER2 therapies, and most recently pertuzumab was evaluated. Pertuzumab is an antibody that also binds to HER2, but it binds to a different epitope than trastuzumab itself. So this was evaluated in the JACOB study, in which it was added to first-line trastuzumab and a fluoropyrimidine cisplatin doublet. Again, HER2 positivity was defined by the current contemporary criteria, and unfortunately this was a near miss. The primary endpoint was median overall survival, and if you look at it, it actually was pretty impressive, 17.5 months, nearly a 3-month improvement, but the p-value just missed statistical significance. It did seem like PFS and response rates were improved, but based on the statistical design, this can only be considered descriptive and is not considered of statistical significance. So one possibility for why this was a negative study was that diarrhea was more common in the pertuzumab arm, and that ultimately required dose reductions in chemotherapy. But I would ask rhetorically whether in the current, in 2018, using an every 3-week cisplatin regimen is the right backbone for ongoing studies. This is the Kaplan-Meier curve from the study. Depending on how you look at it, it was either near miss or not particularly impressive. When it comes to the 50 percentile, we do see that there is a separation, but that seems to close a little bit after that. In either case, further evaluation of pertuzumab is also not being undertaken. Never fear, there seem to be some novel targets on the horizon that are promising. One of these is DS8201. This is a compound from Daiichi, and it's also an antibody-drug conjugate of an anti-HER2 antibody with a topoisomerase inhibitor. And in the US, it actually has a breakthrough therapy designation in breast cancer from the FDA. These are data that were presented at ASCO this year. In 44 patients with treatment-refractory esophageal gastric cancer, there was a high response rate of about 40%, with a high disease control rate of 80%. The median progression-free survival in a pretreated population was also pretty impressive at almost 6 months. So on the basis of this, a randomized phase 2 study is ongoing in East Asia right now. The other drug that's of interest is called ZW25. This is a bispecific antibody against 2 different HER2 epitopes. So it's kind of like trastuzumab and pertuzumab on the same antibody. Data were also presented at ASCO, and in a small number of GE junction cancer patients, there was also a high response rate of almost 45%. And what was particularly impressive was that there were durable responses of 6 months and beyond with monotherapy alone. So moving away from HER2, I want to focus now on anti-Veg F therapy. In this cartoon, you see the various ways we have of blocking this pathway. Bevacizumab, of course, blocks Veg F itself. Ramucirumab blocks the receptor, and both apatinib and regorafenib are TKIs. So after TOGA, the next positive study was the REGARD study, and in 2014, there were data presented for second-line ramucirumab versus placebo. So this was a positive study and improved overall survival by a relatively modest 1.5 months. Of note, ramucirumab monotherapy really has no appreciable response rate, and the major benefit comes from disease control. But the study did establish that it's extremely well tolerated. The only grade 3 toxicity was hypertension in about 10% of patients. This is the Kaplan-Meier curve, and you see relatively modest separation between both groups. Shortly after that, the results of the Rainbow study were presented, so this was also in the second-line space and involved adding ramucirumab to paclitaxel. Again, this was a positive study, and here there was a slightly more substantial improvement in overall survival by 2.5 months. So patients who received the combination lived 9.6 months. That translated to a landmark 12-month overall survival of 40%. Of note, the combination also doubled the response rates to 28% from about 16% with paclitaxel monotherapy. And in addition to the aforementioned hypertension, the only other toxicity of note was grade 3/4 neutropenia in about 40% of patients, but there was not an increased risk of neutropenic fever. This is the Kaplan-Meier curve, and you see a little bit better separation between both groups at this point. So on the basis of these data, ramucirumab was approved in April 2014 as monotherapy, and about 6 months after that, the combination of ramucirumab and paclitaxel was also approved, both in the second-line setting. So in this table, I've summarized all the phase 3 data showing a benefit for second-line treatment in esophageal gastric cancer. We know that doing something is better than doing nothing. We know that a taxane is comparable to irinotecan, and in this context, the clear standard of care is a combination of ramucirumab paclitaxel. I would say, given the modest benefit of ramucirumab, it would be rare to give that to patients in lieu of ram-taxol. So in addition, there also are now data in the third-line setting for the VEGF receptor TKIs, and there are 2 studies that have shown a benefit. The first study is for a compound called apatinib. This is a drug that was developed in China. The study was exclusively in Chinese patients, and the drug is approved only in China at this time. The other study was a randomized phase 2 study of regorafenib. It enrolled Australasian patients as well as Canadian patients. And the asterisk is to remind me that to tell you that there was a progression-free survival benefit, but only a trend towards improvement in overall survival. This is likely because the study had a crossover design. Patients who received placebo could cross over to regorafenib at the time of progression. Here I've shown the improvement in overall survival as well as the hazard ratio for all 3 of these drugs, and you'll see it's strikingly similar. The improvement in overall survival is about 1.5 months. That translates to a hazard ratio of 0.75, which suggests that irrespective of how you antagonize VEGF, and potentially irrespective of the line of therapy, the biologic effect is quite similar. In addition, there have also been first-line studies looking at anti-angiogenic strategies. In fact, the first study of an anti-angiogenic drug in esophageal gastric cancer was the AVAGAS study, and this is a study that combined bevacizumab with chemotherapy in the first-line setting. We all know it was a negative study, but if you look at the numbers, there was again a trend towards improvement in overall survival with a p-value that was respectable, but ultimately negative. However, there were improvements in response rates as well as progression-free survival. This was also one of the first studies in the modern era that suggested potentially a difference in benefit, that rest of world patients might benefit differently, in this case more than Asian patients. And in a subsequent publication, there was a biomarker analysis which suggested that patients who had higher baseline VEGF-A levels and who had lower expression in the tumor of neuropilin-1, neuropilin-1 is a glycoprotein associated with angiogenesis, that these predicted for more benefit from bevacizumab, but only in the non-Asian patients. Not before or since then has there been another publication suggesting a biomarker for anti-angiogenesis, either in this disease or in any other cancer as far as I'm aware. In addition to bevacizumab, there have also been first-line studies of ramucirumab. The first was a randomized phase 2 study performed here in the US that added ramucirumab to FOLFOX chemotherapy. It enrolled esophageal as well as gastric cancer patients, and it was flatly negative. It also raised, I think, the unsubstantiated question that potentially there was more benefit in GE junction than gastric cancer patients. So despite this study and despite the negative AVAGAS study, the Rainfall study was subsequently launched and completed. This was a global study that added ramucirumab to a fluoropyrimidine cisplatin backbone. The study had two co-primary endpoints, PFS and overall survival. There was a very modest improvement in progression-free survival, but absolutely no improvement in either overall survival or response rate. And on the basis of this, there were no plans to seek FDA approval for ramucirumab, and I think the results of all three studies have certainly dimmed enthusiasm for looking at a first-line anti-angiogenic strategy. The next to last topic I wanted to talk about was TAS-102, and yes, I'm aware that it's not a targeted therapy, but it is a positive study. It will likely be FDA approved at some point soon, and I thought it would be important information to disseminate. I wanted to thank David for giving me the slides. So as we all know, TAS-102 is a novel thymidine analog that's combined with a thymidine phosphorylase inhibitor, and it is approved in treatment-refractory colorectal cancer. So in the TAG study, patients who had received at least 2 or more prior regimens were randomized to receive either TAS-102 or placebo, and this was a positive study. The median overall survival was improved to 5.7 months, and this led to a 12-month overall survival rate of 21%. There was also improvement in PFS, and reassuringly, there were no new safety signals relative to the colorectal cancer population. This is the Kaplan-Meier curve from the study, and there's a clear separation in terms of the TAS-102 versus placebo groups. Again, even though this is a targeted therapy study I wanted to kind of compare this with the results from immunotherapy. Specifically, actually of note with the TAS-102 study, the response rate has not been presented, but if it's comparable to the colorectal cancer data, it's likely to be low. Instead, what I would focus on is the 12-month overall survival rate, and I would focus on that from the KEYNOTE-59 study. Specifically, the 12-month overall survival rate was 24%, but that was reported only for all comers. We do know that the median overall survival is slightly better in the PD-L1 positive tumors than the PD-L1 negative tumors. So I would hypothesize that the 12-month overall survival rate is probably somewhere in the neighborhood of 30% in the PD-L1 positive tumors. So to me, this would justify the current practice of offering pembrolizumab in the third-line setting to patients who have PD-L1 positive tumors. For these patients, I do think that TAS-102 would be an option in the fourth line, although even then, irinotecan may remain a competing option. Finally, the last target I'd like to talk about is Claudin 18.2. And actually, these are based on slides that Dr. Albatran presented almost 2 years ago, actually more than 2 years ago at ASCO. So Claudin 18.2 is a major structural component of tight junctions, and this is responsible for maintaining the polarity of tumor cells. It is broadly overexpressed in numerous cancers, including esophageal gastric, and fortunately not expressed on the vast majority of normal tissue. So IMAB 362, which now has a name, is an antibody that binds to Claudin 18.2. And in the FAST study, it was combined with EOX chemotherapy. The antibody is now called zolbetuximab, and 161 patients were treated, and they had esophageal as well as gastric cancers. They were required to have Claudin 18.2 positivity, and that was defined as immunohistochemistry 2 or 3 plus in at least 40% of the tumor cells. The study not only met its primary endpoint, it also showed improvements in overall survival as well as response rates. The combination also appeared to be well tolerated. The only toxicities that were increased relative to chemotherapy were nausea and vomiting as well as neutropenia, but these are the absolute rates and they remain relatively low. So this is a Kaplan-Meier curve, and it's impressive with a hazard ratio of 0.7. Similarly, in terms of overall survival, it's also pretty impressive with a hazard ratio of 0.51. So this translates into an overall survival of 13 months for patients who got the zolbetuximab with chemotherapy. In an additional subset analysis, they then focused on what were called high expressors. So they looked at Claudin staining. So they looked at Claudin staining in tumors in the tumor where it was at least 70%. And here the results are even more impressive. We see a median overall survival of 16.7 months. The one thing I would note also is that the outcomes in patients who receive chemotherapy alone are comparable to historical control, and that would suggest that the Claudin staining or expression status is not prognostic for benefit from chemotherapy. So on the basis of these data, there's a randomized phase 3 study that's ongoing. It's adding zolbetuximab to FOLFOX. The study is enrolling GE junction and gastric cancer patients. It does require positivity, and now the cutoff has been increased to 75%, which is estimated to be about 30 to 40% of patients. Primary endpoint of the study is overall survival. All right, to summarize, for HER2-positive gastric cancer, trastuzumab plus chemotherapy remains the standard of care in the first-line setting. Unfortunately, all other HER2 therapies have failed, potentially because of a failure to identify actually HER2-positive tumors, potentially because of the HER2 selection criteria. Ramucirumab paclitaxel is the standard of care in the second-line setting, and unfortunately, studies of ramucirumab and bevacizumab have also failed in the first line. Apatinib is active in the third-line setting and currently approved in China. TAS-102 is also active in the treatment refractory setting. And finally, zolbetuximab is promising and undergoing phase 3 evaluation. Thank you very much.